Executive Plastic Surgery. So a pleasure to be on another Facebook Live. And so please feel free to ask any questions. This is Dr. Shaher Khan. I'm a board certified plastic surgeon. My practice is exclusively devoted to removal of saline implants, silicone implants, and residual capsules. You know, a lot of interesting patients seen today in clinic. I had a nice patient. She was 70 years of age. She had implants almost a year and a half, and she had what was a grade 4 capsular contracture and a grade 3 capsular contracture. And so it was very nice and tight on her chest, the implant, and causing pain as well on the right side, and on the left side she had what was a grade 3 capsular contracture. The difference between the two being pain. What I'm going to do is, if you will see, if you can give me, I'm going to go ahead and show you. Thank you very much, Mom. So this is where, you know, the patients have, there's four different grades of capsular contracture. As you will see, grade 1, grade 2, grade 3, grade 4. Grade 4 is when the patient had what is a deformity of the breast and painful breast implants, and implant is palpable and visible. And this is what she was on the right side. So that capsular contracture had significantly formed. And on the left side, she was, breast is hardened, implant is palpable and visible, but not painful. And this is what she was on the left side. And the normal one is where you have grade 1, where the capsule forms and it is normal. And it is essentially the scar tissue around where you have the breast is soft, implant is not palpable or visible. And so this is what we are looking for what is a normal appearing breast implant. Now she had, as you will see, a hard breast implant. The capsule had indeed thickened and formed around the implant, as you will see. And as you see in the red nature of it, that you basically have an encapsulation where it's literally suffocating the implant. If you go to my private breast implant illness support group page, you will, and the public page that you're on right now, you will see a lot of these Facebook Lives, YouTube Live, Instagram Live, and TikTok, primarily the YouTube and Facebook Live. You will see that there is, you know, the different rates of capsular contracture we see in the many patients that come. And so she had formed this right around the tissue expander, and that indeed can happen because a tissue expander is essentially like a saline implant, if you will. And so she had the continuation of what was her capsular contracture, despite what was the removal of the tissue expander and placement of a implant, a silicone implant, and she wanted these removed. And as you can see, when the patient has this hard ball, if you will, sitting on the chest, that in itself can impinge on a nerve and cause pain. This is the capsular contracture, grade 4. When the patient takes a nice deep breath, the rib cage goes upward and outward, and as you can see, it expands out. That is prevented when the implant is sitting super tight on the rib, and that capsule that is super tightly adhering to the fascia of the rib and the intercostal muscle will prevent movement of the rib up and out. And that in itself will cause some patients to feel like they have shortness of breath, and that contracture certainly causes a lot more hurt than the pain in itself. So it's a kind of a suffocating type of a feeling. And as you can see, with that nice 70-year-old patient, when she's going to get her implants removed, her neck back pain is going to improve from just not having to carry the weight of the implants. Number 2, the fact that the constriction effect of the implant on with respect to the rib movement is going to be changed. The pain on the nerve that is causing the radiated pain to the neck, back, shoulder area is going to be gone, and she's going to seek benefit from the inflammation that's going to be removed. We know that implants cause inflammation as a direct result of the foreign body sitting in the chest. And so the body recognizes this as foreign. Now, for some patients, it might be relatively very minimal, quote, chemical interaction with this foreign body. And in some patients, it can be severe. So the capsular contracture, we do not know why it occurs in the vast majority of the patients. There are discussions that the size of the implant will, if it's larger, the higher the chance for capsular contracture rate. Those patients that have implants above the muscle, higher chance for capsular contracture. If there is repetitive trauma or biofilm, or when the surgery is not done right, that capsular contracture rate can indeed occur. So the bottom line here is she's going to get the entire implant capsule and all of that inflamed tissue. She's going to certainly look up in the operative record to see if she has alloderm. If I find permanent suture, I will remove that as well, such that all bad tissue is going to be removed, and she's going to left with an AFC, which is an aesthetic flat chest closure. And so basically that is the ultimate goal in the mastectomy patients. We had another patient, two 39-year-old patients that came, and they basically saw me. These are young patients who have the many sign symptoms. One had almost all the boxes of the breast implant illness checked off. And in my practice, you have patients that come to me. I have them basically check the boxes of all the symptoms that they have, from the brain fog, fatigue, fatigue being the most common symptom of breast implant illness, joint pain problems, muscle aches, rashes, hair loss, weight gain or weight loss, temperature intolerance, low libido, autoimmune problems, rashes, GI issues, dryness of the eyes, rashes, shortness of breath, heart palpitations, ringing in the ears, vertigo, anxiety, depression, amongst the many others. So this way I can gauge. And as you can see, those patients did not have any major medical problems, but they had so many of these. And so essentially it's a diagnosis of exclusion. Now, what I want my viewers, listeners, whoever it may be, please ask me questions. This is a question answer session. I'll be more than happy to share with you any knowledge that I have. If I ever do not know anything, I'll be the first person to say I do not know. As you will see, I am Dr. Shaher Khan. I'm a board certified plastic surgeon. We're located here in Bloomfield Hills, Michigan. And like I said earlier, I'm a board certified general surgeon. When I finished my general surgery training, I did burns critical care. And then I am board certified in plastic surgery as well, and my practice is exclusively devoted to removal of saline implants, silicone implants, and residual capsules. So please ask any questions if any of you may have, so I can answer. Now, I just want to mention that, another patient. So I saw another patient today, young patient, 35 years of age. She ended up getting what was in 2014, 11 years ago, a reduction of the breast, where the surgeon went cut around the nipple and then reduced the breast volume. And then 4 years later, in 2018, she ended up getting what was a lift operation, which is kind of the opposite. Now you're adding volume. And she has the many signs and symptoms of what is suggestive and consistent with what is breast implant illness, because she's on no meds, and these are her problems and ailments that she's hurting from, and she checked off a lot of boxes on the breast implant illness questionnaire. The most important thing is she's gone to her primary, her iron levels are good, her thyroid levels are good, she does not have any underlying organic causes for her problems. And so essentially it's a diagnosis of exclusion, and she will get her surgery, where in my practice she has removal of not only the implant capsule plus all of that inflamed tissue. And then number one, all of that capsular tissue is sincerely removed, and inflamed tissue is sincerely removed, and then the implants are returned to the patient. Capsules are sent to pathology, ruling out the BIALCL, that very rare cancer, lymphoma that is associated with the implants. The breast cancer, amongst other pathologies, ruled out, and cultures are done for bacteria and fungus. Now, what I want to go ahead and do is, you want to go ahead and do your homework, and you want to definitely see the high definition pictures and videos of the chest wall showing complete removal of the capsule. And this is one of the 3 take-home messages that I want to pass on to you. And there are many plastic surgeons all over Europe, North America, and in the Middle East who are now doing explants. And it is a very normal finding that, the plastic surgeons are claiming to be end block specialists. The ultimate way to confirm that I or anyone else who's doing it right is to see that the entire implant capsule is removed, and there's no other better way than to see the chest wall showing complete removal of the capsule plus the implant plus all inflamed tissue, and that there is a complete sincerity and honesty and integrity to the whole surgery. Many surgeons unfortunately do not take these videos, and I will tell you, if you do not see a video or high definition pictures of the chest wall, then that means that end block or 100% total capsulectomy was not done. As simple as that. Your surgeon must be an advocate and truly be advocating for you. He or she should only be removing the implants, not augmenting. That in itself nullifies the surgeon. It does not make him or her credible. Remember, you have to always, within the group in itself, seek out those surgeons who are only augmenting. I find in my evaluation of some groups, within a group are 3 surgeons, one of which is only sold unto removal of the implants, and the other 2 are augmenting like crazy, and within the same roof they're benefiting and capitalizing on this other surgeon who is only explanting because they can market him better. So you have to do your homework, and you have to make sure that the surgeon that you're talking to is the same person who's going to be operating. I find some surgeons are talking to a patient and then they get basically sidetracked to another surgeon with a lot less experience, or the one who's supposed to be augmenting only. So you have to be very careful who you talk to. You do not want to be talking to the PA, nurse practitioner, or the front desk person or medical assistant. You want to be talking directly to the surgeon so you get that affirmation. And you want to see a track record of patients, preferably a Facebook group page of that surgeon, by that surgeon, and that is literally grouped together and propagated by the many patients, such that the patients themselves do a check and balance, just like they do on me, on all those surgeons, so that whatever is being done is completely transparent and the surgeon is advocating for what is breast implant illness and the proper and adequate removal of not only the implant capsule but the inflamed tissue around. So I just want to also mention that the second thing is the surgeons must be actively recognizing that breast implant illnesses exist. I've seen so many patients who have come to me with residual capsules where their surgeons are still augmenting. They're not firm believers. They have no track record, no history of doing the surgery right, and no physical objective video evidence of removing the capsule. And now the patients are certainly coming back because they're not feeling better, and they feel like they still have the implants because they know deep down within the capsule was left behind. Either the surgeon may state that he could not remove it, or they cauterize the capsule, which is inadequate. I have had a plastic surgeon who said that he tries to remove it as best as he can, and I'll tell you that's not good enough of an answer. It has to be done no matter what, consistently from one patient to another. There should be no shortchanging or compromise in this surgery, no matter the age, no matter the problems that the underlying patient may be having, be it diabetic or lupus patient or on prednisone. They should get the same surgery regardless of their comorbidities. So it is important to basically standardize the surgery so that there is no compromise in that total capsulectomy or the 100% end block. So we have a question. Please, again, feel free to ask any questions, and I'm here to answer any.
So I have quite a few questions. The first one is, my surgeon used 340 cc on my larger side and 310 on the smaller side. Now the asymmetry looks worse. What are my options?
So the patient has augmentation.
She had an augmentation, but he put a small implant on the small side and a large implant on the large side and made the asymmetry worse.
So this is a technical problem by the surgeon. Now, sometimes you may have a fluid around, there might be more scar tissue. You have to go seek feedback from the same plastic surgeon who did it, because this is a technical problem by the surgeon, and now there is asymmetry that is more pronounced after the augmentation. And so either there is fluid on the inside that's causing this worsened symmetry. Remember, it's relatively easier to fix because the implants, when they are placed, they are sizers that the surgeons place, and then they sit the patient up and then they balance the two sides, and then ultimately they decide that this size is the better size for the patient, and they could be off by 30, 50, 70. So in this case, when the surgery was done, they were likely supposed to be, according to a technically proficient surgeon, both symmetric. If there is asymmetry now post-op, there might be capsular contracture, There might be complications as a result. So you have to seek out that plastic surgeon and have him or her address as to why that asymmetry is worse post-op.
Okay. Next question, is a lift necessary? I have 500 cc implants for 15 years.
So there's a lot this is a very nice question. So if I take, as a plastic surgeon, as a burn surgeon, if I have taken skin that is 10 centimeters from the thigh to donate as full thickness skin graft to another part of the body, and I remove 10 centimeter of the skin full thickness, if I put that 10 centimeter skin on the table, before I put it, let's say, on the face, I will see that 10 centimeter on a young patient like 25 years of age is going to be down to 6 centimeters. So it's going to shrink by 40%, sometimes 30%. The 70-year-old patient that I saw, her skin is going to be shrinking by 10, 15, 20%, depending on the quality of her skin. The very last patient I saw today had a lot of thermal damage, and she had a lot of loose skin because of the solar damage that she had. Patients who drink alcohol definitely have less elasticity in their skin over the years. People who take prednisone, who definitely have less elasticity of the skin. So between that 30-40% recoil of the skin, between the fluffing effect as now the implant is gone, and now the breast tissue, because of the proximity to the implant, is atrophies now with and diminishes and decreases in volume. With the implant gone, physically the breast tissue is going to have a chance to fluff up. Number three, the chest, because the implant sits on the chest, sometimes depending on the capsular contracture or the sheer weight of the implant, can cause a concavity deformity on the chest because the implant is pushing it down. And remember, the bone is always resorbing and depositing and basically being put down. Now with the implant gone, the chest has a chance to now, quote, if you will, barrel out, and so round out. Because as the patients take a nice deep breath and there's no pressure on the rib in itself over the next 3, 6, 9 months, a year and a half is going to round out. And between the fluffing effect, between the excess skin that I remove at the bottom, and between the internal sutures that I put that lift the breast tissue up medially and upward, and between the implant that's literally dragging and pulling the breast tissue down, with that gone, and now the breast tissue has a chance to recoil, the skin has a chance to recoil, I find well over 80% of the patients do not need that unnecessary lift. Also, if the patient has good skin tone, good breast tissue. So post-menopause, the patients have less breast tissue density. So a 70-year-old, when she goes and gets a mammogram, the density of the breast tissue is a whole lot less because there's less estrogen, less progesterone, and the breast tissue essentially atrophies and more fatty tissue. So you will see most, if not all, the patients who are 70 will not only need a breast lift, but a facelift as well, and a thigh lift, whatnot else. So going back to the point, 80% of the patients, if not more, do not need that unnecessary lift. If this was done by a very good plastic surgeon, yesterday, a couple nights ago, I talked to a plastic surgeon who I operated on that came to me from Hawaii, or the 89-year-old patient that I operated on the 14th of April 2025 this year. She, being 89, did not need a formal lift because her surgeon was a phenomenal, superb surgeon. And the surgeon in itself did an excellent job putting the right size of an implant. Now, another patient that came to me had 1200 cc implants. She absolutely needs a lift because her skin is stretched out so much. Another patient who is low BMI, thin, 5'6", weighs 110 pounds. She had 750 cc implant. She needs a lift because her skin is so much stretched out thin. This is very similar to someone who is giving birth and now has triplets. And you can see how much more stretched out. So she will need a tummy tuck because the skin has been stretched out so much. Now going to the average patient, and the average age 35, 45, 55, and average size implants 350, 450. Most of my patients, given the technique above and the dynamics of the chest breast, you will see they do not need that unnecessary lift. Conversely, you will see, look at all those patients that had a lift where there's a cut around the nipple areola up and down and where the skin is brought in, you will see those patients report altered nipple sensation, scar tissue in and around the nipple. They feel sometimes pins and needle sensation, painful scars. Some patients, if they're young, they cannot nurse their children because the ducts were affected, and this has been shown. Not a whole lot, but small subset. We do not know, and no surgeon will promise you. I do not like to cut up and down and around the nipple areola because 1 out of 8 or 9 women will get breast cancer, and when now the patients go and get mammograms, you will see now there's a scar tissue that's showing up, and there's a concern for that calcification, which might be suggestive of cancer. And now the self-monthly breast exam is picking up on scar tissue that might be suggestive of cancer. And now the patients are getting unnecessary biopsies, and plus an unsightly scar. And so the point here is, don't do something that, number one, may not be required, number two, that may ultimately hurt, and number three, that may only hurt you and cause long-term ill effects such as screening. And a surgery that, if done and needs to be, can be done as a staged operation a year out. And as you will see, the vast majority of the patients, well over 80, the many 65-year-olds with 500 cc implants still do not need that unnecessary lift and unnecessary drains. And the patients do, relatively speaking, overall very well, and they're very happy, and minus the unnecessary scarring.
Okay, Dr. Khan, next question. I have Baker 1 and Baker 4 subglandular Mentor Siltex textured silicone implants. She wants to know if the subglandular healing is quicker than the rib cage healing, so below the muscle.
So this is a good question. Any time of the day, I would love to operate where the implant is subglandular, meaning below, sub meaning below the gland, that means above the muscle. This is easier for the patient. The muscle was never cut, and there is no involvement of the muscle in the surgery except for the fascia of the pectoralis major is removed along with the implant and capsule, and easier, better recovery. So just like someone does a tummy tuck where the surgery is done above the abdominal muscles, in this case, the implant is removed and the patients do relatively very reasonably well, and less pain, less dissection time, less chance for issues such as pneumothorax, air within the lung. But you cannot still move your arms about just like you would not after a tummy tuck, and overall a better, simpler, smoother recovery. You will still have to wear the bra and binder, and depending on the size and the amount of inflammation, and I only determine that when I do the surgery, then I follow the patient, and she will have a much better, smoother recovery. And as you can imagine, if the muscle was never cut, the patient never had to deal with the cut muscle and the problems of the cut muscle at the time of the augmentation, after the augmentation, the years that she had the implant, and certainly past the explantation time. Now remember, to put the implant in takes 45 minutes to an hour. To explant takes 4 hours to 5 hours. Depending on the extent of the dissection that needs to be done. So remember, it's a lot more complex, a lot harder. So when I hear that some surgeons are taking 90 minutes, I definitely question the fact that this was even done right. I want each and every surgeon, if I could, in my mind, design a page where I list all the plastic surgeons, probably thousands now in the United States who are explanting, that each one shows and posts high definition pictures and videos of their patients' chest walls showing complete removal of the capsule. If that can be done, how does the surgeon use drains? Does the surgeon use drains all the time? Does the surgeon do a lift all the time? How is the surgeon using it? Does the surgeon a believer in breast implant illness? Many surgeons don't want to even utter the word breast implant illness on a web page, let alone write it, but they want to explant because they certainly want to capitalize on this near very trendy surgery that a lot of celebrities and patients are coming forth for. So going back to the point, do your homework, do your research. After some time, you'll only be convinced. What is ironic about this thing is, if you group together 1,000 plastic surgeons and ask each one of them, there will be major disagreement amongst the majority. They will say that breast implant illness is a myth. I was reading an article, they said that breast implant illness does not even exist. I will tell you, if you read the papers, let's say this is the journal, right? This is the journal that we read. And if I go to the back of this page, and it says over here, and I'm reading, patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. So automatically, right off the bat, anyone who says breast implant illness does not exist did not read this paragraph. Um, uh, and this is all over the plastic surgery journals, textbooks, by the way. And we know that there was a ban in 1992, which did not occur by accident because of all these problems, right? And then it says, quote, individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution. That means a cure. Some patients report complete resolution of symptoms when the implants are removed without replacement. So the bottom line here is you want to do your homework, you want to do your research. If you go to that 1,000 plastic surgeons, many of them will not even want to utter the word breast implant illness. Now, if you go to the group who say breast implant illness exists and you see how each one of them individually is doing their surgery and how they are doing it in their practice, you will see from what I've seen and heard, a lot of surgeons basically say, well, let's see what happens in the OR and then make a determination. This is not how explant surgery is done. The surgeon must be firmly, definitively, sincerely, honestly committed into removing the whole capsule, implant, and all inflamed tissue. That 100-100-0 rule, 100% of the time, 100% of the capsule is removed with 0% of the capsule remaining behind. And that number two, not only so the surgeon should be a believer, but he should be physically be able to carry that surgery out. So I have a close friend of mine who says, I believe in breast implant illness. But if you ask him consistently from one surgery to the next, he says he's not able to carry it out. So when the implant is above the muscle, he says, I have a better shot at it than when it is below. Or when if it's ruptured, it's a lot harder. And he's putting in drains on all the patients. And if you ask me, this surgeon truly does not and is not doing the surgery in the adequate manner, so that we do not want the silicone to spill into the chest. We do not want any of the capsular tissue to be left behind. And that there should be no need for that unnecessary drain. So another way to answer the question is if your surgeon is doing it right or wrong. In my eyes, as a board certified plastic surgeon who's explanting exclusively, if your surgeon is not using drain, that definitely gives him a good big plus check, nice feedback that he's doing it right, because he's not letting any of the silicone spill into the chest. He's not leaving out the capsule behind. He's not rushing to the surgery. He's not rushing through cutting the muscles, whatnot else. And quote, he's more sophisticated and calculated into removing, and that he or she again has the high definition videos and pictures of the chest wall showing complete removal. Your surgeon cannot state, if you ask me, oh, I cannot do high definition pictures and videos. Remember, we as plastic surgeons, if you want to tell one plastic surgeon apart from another doctor at the hospital, is that he or she will always be carrying their camera. So we always carry our camera so that we can see the before, during, after a dog bite, or a hand injury, or a face laceration, or skin cancer. So we can basically say this is how the patient was before, during, and after. So the surgeons we are trained into taking pictures and high definition videos, and that every surgeon must document complete removal of the capsule, because that's the only ultimate way. And OpNote is certainly the old-fashioned standardized way, but I find the ultimate, when it comes to explant surgery, the video is key.
So the same patient who asked that question wants to know if the size of the amount of fascia you take out is at the same size as the capsule.
So this is a very good question.
Yeah.
So when the implants are put, they're normally put 2-3 finger breadths below the clavicle, and the implant sits in the upper part of the chest, because that's normally rare in a human and the normal anatomy. That's where the breast tissue sits. Now, over time, as you will see, the vast majority of the patients will attest to the fact that implants and the breast tissue starts moving down. The breast tissue kind of gravitates down along with the implant. And so now the capsular spread, that means the capsule that was once up here gets elongated, and you see the implants kind of move around. Not in all the patients, but you will see those patients that do not have a capsular contracture, now the implant's moving down and outward. And so you'll see most of the patients have their implants kind of hitting their arms. So they're bottoming down, they're much further down from the clavicle. Now, when I do the surgery, I remove the implant capsule that's down here, but that capsular tissue and the spread on the fascia is much further up. So as you will see, go to my YouTube page, Con Plastic Surgery Academy, or Executive Plastic Surgery YouTube page. It's on my Facebook. It's also on my executiveplasticsurgeon.com. And I want to go to YouTube Shorts. YouTube Shorts. And you will see, if you scroll down, you will see the high definition pictures and videos, many of which have been posted and many of which are going to be coming forth. You will see that the incision is generous enough not only to remove the implant capsule here, but all the way up into the upper part of the chest. And so for me, as a board certified plastic surgeon, I question all the other surgeons who are making a cut up and down and how they're able to split open the chest and make that, quote, lack of a better word, barbaric cut up and down through the breast tissue to now dissect on top of the rib. The best and the simplest manner is to dissect parallel to the rib, an incision that's horizontal only, that hides right in the crease. And then as I dissect, I look into the chest underneath the muscle in the vast majority of the cases where the implant is below the muscle, or in the few cases where it's above. And then I remove the whole capsular tissue and that fascia such that the entire burden is removed, not only from the bottom, but also from further up. Because remember, this is where that capsule was sitting initially when the patients first had the implants. So, and in my practice, very important, I remove not only the implant capsule, the inflamed tissue, but also the fascia of the intercostal muscle, fascia of the serratus anterior muscle, fascia of the pectoralis minor. This is on the wound bed. And then the periosteum, perichondrium, and then the fascia of the pectoralis major inferiorly, such that all of that capsular burden is removed along with the fascia, so that there is no potential for break in that capsular tissue. And so the end block is accomplished. And this is a 4-hour commitment, maybe 5-hour commitment, whatever length of time it takes for me to doing the surgery correctly. I did a case almost 2.5 weeks ago on a Thursday where I did 2 patients back to back, both of which had both of their implants ruptured. The first one was an implant from 1982, 43-year-old set of implants, both right and left, was very easy, relatively fast, quote unquote, a piece of cake, versus the one from 2010, the next patient that I did. And she had what was a much more involved case, more challenging, more involved, difficult, even though she was also ruptured because her surgeon and how and what her dissection was like and how the implant had ruptured. Her implant, interestingly, from 2010 was much more liquidy, more gel, less gel-like, less gummy bear, and more liquefied than the 1982 implant, which shows that the newest set of implants, the gummy bear safer better, are not any safer. They're essentially the same problem because they liquefy, they melt, and they cause the silicone toxicity, if you will.
Okay, next question. Will you do a fat transfer during an explant?
So this is a very good question, and I want you to look into risks of fat transfer. Risks of fat transfer. So as you will see, number one, these are the risks for fat transfer. You can have a problem at the donor site, and where at the recipient site, the breast tissue, some patients have reported altered sensation, nipple tingling sensation, pain sometimes, irregularity. Sometimes the fat takes on one side and it doesn't take on the other, and on the other side vice versa, and now you have an irregular contour because some of the fat got absorbed, some of the fat deposited, and it was done in a systematic, symmetric way, but the end result was some of the fat got absorbed, some of the fat took. Sometimes some of the fat takes and it forms clumps of dead nodular fat necrosis, dead fat, because it just for some reason did not get the blood supply. And now when you feel a breast mass. Not in all, in small subset of patients, and it's been reported anywhere from 3%, 5, 10%, depending on the surgeon's technique, how much of the fat was transferred and transplanted. So you will see that mammograms are picking up on these calcifications, irregularities, masses, also the self-monthly breast exam, and now the patients are getting unnecessary biopsies. And it could be in anywhere from 3, 5, 10% of the patients. You have patients with oil cysts that form, patients that have the asymmetric contour, the voids that occur. You have the scar tissue that forms as a result. And overall, fat grafting, as nice and organic as it sounds, if you ask me, I say malpractice, because you do not want to alter the self-monthly breast exam and the mammogram, even in the small subset of patients, in the name of aesthetics, where 1 out of 8 or 9 women are going to get breast cancer. So look up the risks of fat grafting. Now, fat grafting to the face, excellent idea. Fat grafting to a bad scar on the thigh, excellent idea. Because they really have a lot of stem cells and scar rejuvenation, among other benefits. But fat grafting to the breast, I use the word horrible, and I use the word malpractice, bad medicine. We do not want to give cancer the chance to win. So the other thing I want to mention, going back to the question before, my best patient is the one who is well-read. My best patient is the one who is post-menopause, because the dissection is better in those planes. The patient who has smaller implants, the 125cc implant is better to remove than the 800cc ruptured implant. An intact implant is definitely easier to remove. An implant that's placed by a board-certified plastic surgeon is definitely easier for me to remove than an implant done by a non-board-certified plastic surgeon, which basically means, believe it or not, right here in Michigan and in the United States, there are general surgeons who are putting in implants, gastroenterologists, emergency room doctors, ENT specialists who are putting in implants, OBGYN who are putting in implants, and this is all on the job training. These doctors do not have hospital privileges. There are many cosmetic surgeons who unfortunately are doing implants, and this is all on the job training. But you've asked these cosmetic surgeons, can you do this operation at the hospital? They certainly do not have privileges, because they're absolutely not taught right. So you want to do your homework? Do you want to do your research? It certainly is very important for you to know who your surgeon is. Again, your surgeon must be very transparent, willful, and very energized about doing the surgery and doing it right. And they should openly declare and discuss as to why and how they're doing it. I find one patient last week complained, here is a surgeon who has a liaison, who basically is doing all the talking, all the verbal discussions, the constant phone calling and saying, well, this is your best surgeon, and advocating for the surgeon and saying that they're patient advocate, but at the same time, there is a financial kickback with regards to this liaison working on behalf of the surgeon. In some cases, a Facebook group owner is backing up another plastic surgeon because they get financial kickback. You want to be very careful, and you want to see that the surgeon is honest, sincere, and there is no financial commitment of the surgeon. As far as myself, I have zero financial disclosures. I have no commitment to anyone except for my patients, so that they ultimately get better. And my commitment is only to the patient. I've been invited to donate to basically prove of another practice, so that they would send me patients and I would get kickbacks, and I obviously always said no, because this is not my vested interest. Again, do your homework, do your research.
So I just want to briefly answer, we have multiple questions, but one lady wants to know the average cost. I just wanted to let her know to give us a call, and we could get a consultation going for a quote.
Yes, so very important. So I will tell you, in my practice, they're very open. So someone who comes to me from Europe, from California, from Texas, from Michigan, they get the same price. So what we have right now, in order to simplify things, tier 1, where you have less than 500, non-ruptured, straightforward 325cc saline implant. Tier 2 is when you have, more involved care. For example, you have above 500, you have a ruptured implant, you have leftover spilled silicone from an initial silicone implant that ruptured and now was free floating and bathing the tissue. You have another patient that has bilateral 800, that's tier 3 is bilateral above 500, both 800 cc's, both ruptured on a previous radiated patient. So tier 1, tier 2, tier 3. If you call the office, again, the number is 734-459-1615, executiveplasticsurgeon.com. We will be able to share that information with you. And again, do your homework, do your research. In my practice, as you will see, I love to operate. I wish I could be operating right now, but no unnecessary surgeries, no unnecessary drains, no unnecessary lifts. How many of my patients, and I will say thousands, who have gone by without unnecessary lifts and they have done very reasonably well and they're very happy they did not get shortchanged by doing what are unnecessary procedures. This very last patient, she came in, she wanted a brachioplasty where you remove the excess skin on the arm, and I told her, she's a nice 65-year-old lady, I told her, listen, go work out an extra half an hour per day, build up the muscle mass, that 10-15% muscle mass to your biceps and triceps and the deltoid. You will not need that unnecessary brachioplasty. And you know what? She got motivated and she does not need that unnecessary surgery. Is that one less surgery I did? You bet. But guess what? That's a happier, better, nicer patient, and that's what she deserves. Surgery is, sometimes when we walk into a plastic surgeon's office, the simplest answer is, well, we have a date open next week. I could have said that is wrong and bad medicine. This is not how ethical plastic surgery is carried out. The bottom line is educating the patient and avoiding the surgery, because surgery is the last option.
Okay, next question, Dr. Khan. Would the drain give the body a break and help the body detox faster?
So that is a very good question. Now, as you will see, how many of my patients, the last time I used to drain was well before 2020, well over 5.5 years ago. How many of my patients called me up or posted on Facebook? Remember, they have the transparency. This is the transparency that I'm talking about, where a patient can go online and talk about me and say, well, this was my experience with Khan, excellent surgeon, but I needed a drain by another doc when I went back. Remember, 8 or 9 out of my patients come to me from out of town. They do not need a drain because they did not need one. The blood loss is less than 5 cc's in well over 99.7% of the patients. I remove all the badness. There is no burden remaining behind. Look how many of my patients are supremely happy and free and minus all those toxins. The drain the drain in itself is notorious detrimental and can be hurtful. If the silicone spills into the chest, if the silicone is basically free floating, if the capsular tissue is left behind, or if there is quick rushing through the surgery and now the tissue is weeping, now the drain becomes mandatory. So the burden lies not on me as to why I don't use drains. The burden lies on all those surgeons as to why they are, because I presented at a World International Plastic Surgery Conference in Dubai in 2023. And I said, listen, I've done so many of these, thousands of these explants, and the drain was not even required. And I showed the pictures and the videos. Even the 1200 cc implant, I did not use a drain in her because it was not required. Did she call me afterwards and say, hey doc, I needed to get a drain? How many of my patients have called? No. The only very minute, small subset of patients who have needed that fluid evacuated are the ones who chose not to wear the bra and the binder, who were starting to move their arms around just like after a tummy tuck, and now the sheer forces causing movement of the skin and the breast tissue with respect to the chest caused that fluid to accumulate. Just like after a thigh lift or a tummy tuck, you would not wear the pressure garment or you would go do crunches, you're going to make the fluid build up. And this is precisely why. Now, the drain in itself, believe it or not, just because you have a foreign body in the chest, will induce some fluid formation because it is an irritant to an extent. If this is the chest and the tube goes in and out of the chest, that bacteria on the tube outside can seed inside the bacteria and it can be a catastrophe. The other thing is, if the the bulb syringe opens up, and now that fluid inside backtracks into the chest, that's going to be a major catastrophe as well, because that fluid is not sterile. So remember, drains are very much needed when there is an indication. So in my practice, those 7 drains that I've used, as soon as I made cut, there was free floating silicone everywhere, because this 81-year-old lady was involved in a car accident, and the implant had indeed very much ruptured, and it was already free floating, so that end block could not have been done. That patient bought herself a drain. Another patient, she had a 4-year-old kid literally knee her. She was on her knees and trying to hug her 4-year-old kid, and her 4-year-old child literally lifted the knee up and hit the knee into the chest and caused instant pain, and the patient got the referral to see me, and lo and behold, as soon as I made cut, there was free floating silicone. Now the drain requirement is already met because she bought herself the drain. The decision was already made. But in the vast majority of the cases where the implant was ruptured, I did not know. I still went and did the end block or 100% total capsulectomy. All the badness was removed. Everything was contained. The drain requirement was not there. And the patients do very well without the drains because they're not required. One patient asked me, I love everything you're doing. I want you to just put a drain in because it's going to be peace of mind. You do not want to get a drain because someone else said that you have badness that's going to drain out. If there was badness, it was going to drain out no matter what.
Okay, next question is, once you explant, what is left?
So this is a very good question. So if you go look on Google, type in pectoralis major, you will see below the pectoralis major muscle is the pectoralis minor and the ribs. So when I remove, and if you can imagine, this is the pectoralis major muscle, the breast tissue is above, the implant is below the muscle, and this is the rib, if you will. So I'm always below the muscle in this P2 compartment, if you will. P1 compartment is above where the breast tissue is. A month and a half ago, I did a Facebook Live with a nice young lady, and she was actively nursing her child. And she nursed her child in the morning and after the surgery, because this is where the breast tissue is and the nipple areola, and she can do all what she wants. This is independent. I use the word irrelevant to me. The breast tissue is above the muscle. Below the muscle is pec minor, pectoralis minor, and the ribs. So there is no volume that I'm removing. And so I'm always in this P2 category below the muscle. I do not touch the muscle because I'm always below the muscle. I do not cut up and down the breast tissue because I'm not cutting into the muscle. I'm always parallel to the muscle, underneath the muscle. And then I remove the implant and the capsule and any of the inflamed tissue. So I'm not removing any breast tissue. I'm not removing any precious volume. And I'm only removing the implant capsule. So on the day that anyone gets surgery from me, I'm removing the implant, I'm removing the capsule, and there is some swelling, inflammation that's present as a direct result of the implant. You can see the dilated green veins. So when the implant and the capsule and that inflamed tissue comes out, everything settles. So I'm not removing anything. I'm not touching the breast tissue. I have not touched the breast tissue in any of my patients. And so the point here is, whatever you have breast tissue above the muscle is what you were born with genetically. And as you will see, that breast tissue is intrinsically what you were had you had a twin sister or had you had no implants. And so that is the volume. Now I find from my experience, like I mentioned very early on in this Facebook Live and YouTube Live, TikTok Live and Instagram Live, that with the implant gone, and a mass effect of the implant in the proximity of the breast tissue atrophies. Now with the implant gone, the breast tissue that's being diminished because of the presence of the mechanical presence of the implant, with the implant gone, the breast tissue gets a chance to fluff out and breathe. And the inflammation subsides, the recoil of the skin occurs, and now the patients overall do very well. So I jokingly say to my patients, if your complaints are you do not have much breast tissue, you have to complain to your mom and dad for the genes that you did not have much breast tissue, or you have to complain to God because that's what you were. I'm not going to add excess tissue The only way you can add excess tissue is fat grafting, which I already said no. The other way to doing it is taking fat from the belly and then microtransfer with microsurgery, which is a deep flap, which I would not recommend. I would not recommend a latissimus flap. And this is where you do not want to burn another muscle, if you will, and have a big scar in the back, which is a latissimus transfer to build volume. After some time, when you even transfer the muscle atrophies or diminishes significantly unless it's reinnervated. And the bottom line here is the goal of the surgery is to remove the implant capsule and all of that inflamed tissue completely, sincerely off of the rib, which is true for a majority of the patients below, and leaving the breast tissue alone.
Another good question here. If the implant is above the muscle, is the breast tissue affected? Will I be able to breastfeed after removal?
That is correct. So if the implant is above the muscle, it is below the breast tissue. I do not touch the breast tissue. Again, there is a nice fine boundary between the implant and the capsule and the breast tissue. I always will ride the capsule or tissue such that the breast tissue is not touched, and you certainly will be able to go through the nursing breastfeeding without any problems, because I'm not making any cuts into the breast tissue and I'm not cutting in and around the nipple areola. I do not make that S or the J cut because I do not like cuts around the breast tissue and around the nipple areola, which are absolutely not needed in the vast majority of the patients in my practice, in my technique.
Do you think fat transfer is safe due to stem cells from fat?
So I will tell you, as I mentioned earlier, if you go listen, and you can certainly Google this on the as you do your research, fat grafting will lead to oil cysts, fat nodularity, dead fat in and around the nipple areola, pins and pain needle feeling, not in all, small subset of patients. You will have irregularity. You may have deposited it evenly, but after some time, some of the fat may not take on this side, may take on this, and may take on other areas. And so you would have dimples and divots and irregularities and painful sensations, altered self-monthly breast exam, altered mammogram in a small subset of patients, and mammogram will be altered self-monthly breast exam, looking for 1 out of 8 or 9 women who will get breast cancer. That will be, certainly be affected negatively. And so I myself, as I mentioned earlier, fat grafting sounds good, looks reasonable. In reality, I see in my practice a malpractice, not worth it idea.
Is capsulectomy the same as en bloc?
So this is a very good question. I want you to please go to my my YouTube page, and I want you to see this very definitively where I describe, and I will go ahead and do so like right now. So if you have a patient that has the implant and the capsule removed completely without a break in the capsule, this is an en bloc. Now let's say if the surgeon was doing the surgery fast and not concerned or thinking that the implant is not ruptured, or is saying that the capsule is so thin, or if the capsule is super tightly adherent to the rib and now there is like a 1 millimeter break, that en bloc does not apply, but the surgeon removed the whole capsule. This is called 100% total capsulectomy. 100 meaning 100% of it, total means complete 100% capsulectomy. Capsulectomy means removal. Now, if the surgeon goes in and says, you know what, I'm going to just remove this top part, but the part on the rib, I'm going to leave that behind such that I'm only going to remove the capsule, but I'm going to leave the capsule on top of the rib as is because it's too hard. I don't want to get a pneumothorax. This partial capsulectomy, no. Bad idea. The whole goal is if this implant is ruptured, we do not want it to spill into the chest. Now, I myself, if you have seen the many Facebook Lives, I'm able to plug it, suture it, close it, put a ray tack, do this as the last part such that the entire implant capsule is removed. Even if it's ruptured, there is fluid, none of this leaks out. And this is done where now the drain requirement is not there and there is no spillage. So en bloc, the desired, which is called the gold standard. 100% total capsulectomy, excellent, gets the job done, and the surgeon is very focused not to allow that silicone. No surgeon can claim they do end block 100% of the time because this is virtually impossible, even in my hands and eyes. But this is at least, and this is the only next best thing, which is the 100% total capsulectomy. Partial capsulectomy, as is in this case, even leaving 5, 10, 15% is not good enough. And capsulotomy, which is another where you're scoring the capsule such that you are breaking the capsule, but the capsule base behind is a big no-no as well. So partial capsulectomy and capsulotomy is a no. And I have this up on YouTube, and I'll post this on my private breast implant illness support group page and my public page, so you can see exactly what I'm talking about. And this is kind of a nice tutorial that I've done on my YouTube page, so you can see.
Okay, do you ever use or see the need to use incisional vac on those incisions?
So this is a good question. No, there is no reason, no indication for that. So there is a VAC device which is called vacuum assisted closure. You can Google this, VAC, where you have a sponge or you have a special fancy dressing, which there is negative suction that helps with patients who are, for example, tummy tuck patients, patients who have open wounds. Do you want to induce granulation? There is no indication or need for that because it is not required.
Okay. Right. I got my implants 8 years ago, and supposedly they're gummy bear implants and don't need exchange. That's not correct.
So that is, absolutely. So I'm going to say this to you. If you go look at this plastic surgery journal, right, and here, look, they're advertising Natrel. Our commitment to safety is backed by real world data. Very interesting. And more than 1.8 million. If I turn this around, I'm going to read this. Breast implants are not considered lifetime devices. The longer patients have them, the greater the chances that they will develop complications, some of which will require more surgery. Not my words. There is no such thing as a permanent gummy bear implant. Wrong information, 100% wrong, incorrect. Even saline implants, they cause the same hurt as silicone implants, and they do rupture, and you need, anecdotally from my practice, I've seen 7 to 10 years before they start giving trouble. If you look at the FDA and the warnings by the manufacturers, they will tell you 10 to 15 years, some sooner, some later. But whoever told you that the implants will be with you forever, absolute 100% false. Wrong information. Please do your homework. Ask your plastic surgeon to write it down, and I want to see it, because that's not going to happen. You will only hear that they need to be replaced every 10 years, plus minus, some sooner, some later.
So that's all the questions that I've received. I don't know if you...
Okay, so we're 57 minutes into this. Now, what we want to do here is now, how long do you want your patients to sleep on pillows after explant? So this is a very good question by one of my very recent patients. So if someone has chest surgery, you will see those patients that have had open heart surgery, you'll see they're going to be leaning forward, and so not to put pressure. Some patients are restless sleepers. They will be twisting and turning. So all my patients who have had explant surgery, because of the surgery was done on the chest, you're going to see they're going to be leaning a little bit forward because they do not want to put pressure. Conversely, you do not want to be, after this surgery, kind of going like this and spreading your chest out, because that's going to affect your wound bed, and this can be an extensive area of dissection. Now remember, you're going to have the bra that's going to hold you like this, and then the binder that's going to kind of give you a push up, so that when you are in a car, there's no movement up and down. And so this is that added reinforcement, if you will, by the binder, and so that as you sleep and you turn to the side, you're fine. Now I tell my patients, if you're a restless sleeper and you're twisting and turning and quick movement while sleeping, some people like to sleep on their stomach. I tell them sleep on a lazy boy chair, because you're not going to be sleeping on your stomach on a lazy boy chair or on a couch. Now, I know it's uncomfortable, but the whole goal is when you're sleeping, and especially when you're not feeling the pain, you do not want to be up and about. Now, if you are wearing the bra and binder and you are turning to the side slightly, perfectly fine. You can be even more so to the side, but you do not want to be twisting and turning. The other thing I tell my patients, sleep on 2 or 3 pillows. So that as you're getting up, you're already 1/3 up, so that you're using your abs and your thigh muscles to get up, not your arms, because you do not want to use your arms, because then you're going to inevitably end up using the pec underneath which majority of the surgeries occur. And so that's the whole idea, that as you get up, you're using more of your abs and your thighs and no arm usage whatsoever. One patient said, well, I use my T-Rex position and I'm like this 90% of the time, only 10% of the time I'm like this. I said that 10% is going to get you into trouble. This is just like saying I got a knee replacement and 90% of the time I'm fine, but 10% of the time I'm walking and going up down the stairs and ambulating on it. No, that 10% is going to cause the hurt. Remember, this is a surgery. If you ask 100 surgeons, 95 of them don't want to even hear the word this surgery, the breast implant illness, total capsulectomy and block. And of the 5, they will attempt to want to try to remove. And this is a surgery where if you look on YouTube shorts, how extensive and involved the section is right on top of the rib. And you do not want to complicate a surgery and the recovery. So you have to respect the surgery, you have to respect the recovery process. Now, this is very analogous to you sprain your ankle. That 18-year-old boy who's playing basketball 2 days later is going to be limping 3, 4, 6 weeks out because he never listened to his ankle. The other nice, smart, wise lady, which all of you are who are listening, rest, compression, ice, elevation, crutches. 2 weeks later, you're running a marathon because you respected the ankle sprain and you let it heal fully. And that's how you want to do it. So listen to your body. Don't do anything. Absolute sincere T-Rex. I had a patient that put a tie around and she was following my instructions. And I'll tell you, at 5.5 weeks, I moved her forward. I have another lady, very nice, but she's a single mom, 3 kids, very much active, taking care of the kids. That's like more than a full-time job. That's like double full-time jobs, 24/7. She's moving her arms about, and 8 weeks later, she's telling me, I'm still hurt, and sometimes I still get a spasm. She's already 2 weeks behind her recovery. So you want to let yourself recover optimally so you don't run into the problems and you respect the recovery, less chance. Sometimes what happens is, many of the patients, they say, oh, they're doing so well, now they don't feel the pain and they feel like they can start moving their arms. No, you want to respect that recovery of the 6 weeks, just like you would after a tummy tuck. And once you have recovered fully, then you will gently start building on those muscles, not only the pec major, pec minor, but the deltoid, latissimus, serratus, all the muscles of the neck, back, shoulder. And you will not only improve your posture, but all the muscles of the neck, back, shoulder as you get older. So this was a very good Facebook Live. Hopefully you found this informative. I plan on doing this another question answer session hopefully next week. Please feel free to ask me any questions. I will end with this. I have a very good, nice, wonderful patient from Hawaii. And she asked a question earlier. Her almost 30-year-old daughter wants to get implants. And she herself explanted with me. Today I saw another lady, believe it or not, her mom I operated on, and she sent her mom to me. And so now she comes herself. And so the 30-year-old who's interested in getting a augmentation, I just want to share this with you. You're the boss, you decide whatever you want. But this is a checklist of the problems that this FDA wants you to understand that and acknowledge that you understand what and how the implants could potentially cause harm to the body. So first of all, there is the boxed warning that we saw earlier. And the box warning, and I'm going to take like 5-7 minutes to read this just so that you get the understanding and gist of it. You can actually go to Google, and I want you, each one of you, to type this in because you will see this for yourself. Breast implant, certain labeling recommendations to improve patient communication, guidance for industry and Food and Drug Administration staff, document issued September 29, 2020 by the FDA. and saline silicone gel and alternative breast implants. So in this, they want you to know breast implants are not considered lifetime devices. The chance of developing complications increases over time. Some complications will require more surgery. Breast implants have been associated with the development of the cancer of the immune system called BIALCL, which is the breast implant associated anaplastic large cell lymphoma. And then they mention over here, breast implants have been associated with systemic symptoms, which is BII, patient decision checklist. And they want, the FDA recommends that a copy of the patient decision checklist be provided to the patient so the patient can refer back to this important information. So inadequate to just show in the office, the patient should go home with them. And to basically let it sink in and digest and process this information. Rupture screening recommendations update. Physician labeling. For asymptomatic patients, the first ultrasound or magnetic resonance imaging should be performed at 5 to 6 years postoperatively, then every 2 years thereafter. For symptomatic patients or patients with equivocal ultrasound results for rupture at any time postoperatively, an MRI is recommended. Then they want you to know that they want the card issued to the patient. Here is the black box warning. Breast implants are not considered lifetime devices. Breast implants have been associated with the development of the cancer of the immune system called BIALCL, and at the end they mentioned some patients have died from the BIALCL. Patients receiving breast implants have reported a variety of systemic symptoms such as joint pain, muscle aches, confusion, chronic fatigue, autoimmune diseases, and others. Individual patient risk for developing these symptoms has not been well established. Some patients report complete resolution. That means cure of symptoms when the implants are removed without replacement. Here, what are the patients who are successful candidates? That I'm not a candidate if you have an active infection, existing cancer, you're pregnant or nursing. If you're nursing, you have a high risk for a poor surgical outcome if you have diabetes, connective tissue problems, active smoker, taking drugs that weaken the body's natural resistance to disease, such as steroids, chemotherapy agents, history of chemotherapy or planned chemotherapy. Look at 90% of the breast reconstruction in cancer patients is done via implants. History of radiation therapy or planned radiation following breast implant placement. Then they talk about, and now they want patients to initialize. They tell you breast implant surgery risks include breast pain. It says reported in up to 36.5% of procedures, skin or nipple areola sensitivity changes, asymmetry, infection, swelling, scarring, fluid collections, hematoma, tissue death of the breast, skin, or nipple, inability to breastfeed, complications of anesthesia, chronic pain, damage to surrounding tissue such as muscle, nerves, and blood vessels. And then my physician has discussed these risks and has provided me with the patient information, patient initials, the risk of the BIALCL again. It says over here, I understand that the treatment for BIALCL involves an operation to remove the implants and the surrounding scar tissue capsule. And that's the whole essence of surgery. Anyone can remove implants, but you have to remove the whole capsule. And this is why 3 of my patients in the last year and a half who had CD30 positive, they got this surgery anyways. And they want the patient's initials. And as you will see, systemic symptoms. Again, the same thing. I understand that some patients who have reported breast implants have reported a variety of systemic symptoms, including joint pain, fatigue, rash, memory loss, brain fog, that some patients have called breast implant illness. While the causes of these symptoms are unclear, some patients have reported relief of these symptoms with removal of their implants and surrounding scar tissue capsule. So they're telling you scar tissue capsule needs to be removed. However, not all patients may experience improvement in their symptoms. I also understand that some patients with breast implants have reported health problems in their children after birth or breastfeeding. Patient initials. I understand breast implant is not a lifetime device, and the longer I have my implants, the more likely I am to experience a complication, and more likely I am to require reoperation, requiring the placement or removal of my breast implant. As many as 20% of women, that is 1 out of 5, as many as 20% of the women who receive breast implants for augmentation have to have their implants removed within 8 to 10 years. Now, I understand my breast implants may rupture or leak at any time, and that the longer I have my implants, the more likely I am to experience a complication such as rupture. And then they tell you over here, I understand, this is very important. I understand that silicone can migrate from my implant into nearby tissues, chest wall, lymph nodes under the arm, and organs, liver, lungs, where it may not be possible to remove. I understand that all breast implants can interfere with mammography and breast exams. This alone should be a reason to ban implants. I understand that all breast implants can interfere with mammography and breast exams, which could delay the diagnosis of breast cancer. Mammography can also cause the breast implant to rupture or leak. And I understand that the long-term risks of breast implants include painful or tightening, rupture or leaking, wrinkling of the implant, visibility of the implant edges, shifting of the implant, need for reoperation. I understand that all breast implants contain chemicals and heavy metals. Patient initials. I understand that breast augmentation may result in permanent changes to my breast tissue, and if my implants are ever removed, I may be left with unsatisfactory appearance, changes to size and shape of my breast, including but not limited to dimpling, chest wall concavity, puckering, sagging, and different incision size or location. If I'm an augmentation patient, any additional surgeries or medical procedures will likely be at my own expense. Patient initials, patient signature, physician signature. It doesn't say medical assistant signature, nurse signature, receptionist signature, nurse practitioner signature, physician, surgeon signature. And what are the heavy metals? Heavy metals found in breast implants: arsenic, barium, beryllium, cadmium, chromium, cobalt, copper, lead, magnesium, mercury, nickel, platinum, selenium, silver, tin, titanium, vanadium, zinc. Now I'm going to go ahead and, if I have not scared your daughter, and I don't want to use the word other than the word scared, because I'll tell you, I myself as a physician, as a surgeon, I'm scared just by listening and just by reading this. Scared is the right word, because this is part of the informed consent. This is where, look, the patient just said, my surgeon said they're going to be with me forever. There is a very real, but very, 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 very low association with BIALCL. And that's why whenever the capsule is removed, it must be checked. Now, anything that I have said, if you read this one with an open mind, why would you want to take the risk of all these problems, right? Is this worth it? I will tell you, I myself, as a board certified plastic surgeon and a human, and as someone who's processed this and who I've taken care of, why do a surgery where, if not all my patients have said one of these two things? Number one, they wish they had never gotten implants. They wish they had removed them sooner. Why would you want to do a surgery where the patients and the celebrities are coming forth and saying that the implants hurt them? Old and young, of all ages, from all walks of life and all over the world. Look at how many explant surgeries are being done in Dubai now and Europe. And the bottom line here is there needs to be a standardized, systematic, thoughtful way where the plastic surgery societies are now talking to the plastic surgeons and saying, you know what, we got a real problem, and we're going to come up with a nice standardized way so we can educate the patients and tell them that this is the most straightforward, complete, transparent way, so that when the patients look back at my surgeries that I've done, and I've said this so many times in my Facebook Live, and I'll end with this, I could not have done it better. And this is the con procedure: no unnecessary lift, no unnecessary drains. Pathology specimens are sent to the capsules, are sent to pathology to rule out that rare BIALCL, breast cancer, lymphoma, squamous cell cancer. Microbiology cultures are done for Arabic, anaerobic, and fungal. Implants are returned to the patient. The high definition pictures and videos, not only of the chest wall, but the video of the chest wall showing complete removal of the capsule and cutting open of the capsule in all the patients 100% of the time. And then twilight deep sedation, and no matter what the comorbidities are, that all patients get the same surgery, so that there's complete removal of the implant capsule in what is that en bloc fashion, or 100% total capsulectomy, so that the patient gets the complete chance for quote unquote relief that they very much are looking for. Now, thank you very much for listening. Hopefully you found this informative. and please share and educate each other. You know, it is relatively speaking very involved and very can be overwhelming, but after some time you will see the same theme will repeat itself. This is Dr. Khan, Executive Plastic Surgery.